So the sexually transmitted infections, they are very common. So if I show you this picture, what do you see here? Like what is this adhesion?
Adhesions.
Yeah, these are adhesions. And is there any specific name? Because these are adhesions between the diaphragm, that is on the anterior abdominal wall, because it is a fan-shaped muscle separating the
Mm-hmm.
abdomen from the chest like that. Okay, so it is spreading across the diameter of this junction between the chest and the abdomen. So there are these flimsy adhesions. They can be thick, but there are adhesions between the diaphragm and the anterior surface of the liver like that. So what is the name of this syndrome?
Um,
Fisz-Hugh-Curtis syndrome, right? Fisz-Hugh,
yes, yes,
Fisz-Hugh-Curtis
yeah.
syndrome. So associated with chlamydial infection. So here we are seeing,
Chlamydia infection.
yeah. So here we are seeing some mucopurulent discharge from here. Okay. So this patient most likely have chlamydia. So this is just for the sake of like
Mm-hmm.
reviving that. You should just try to memorize that what we have, what do we know about this condition. So the sexually transmitted infections are very important, and PID is the most common cause of the PID is the ascending infections from the cervix to the upper genital tract, and which are caused
Mm-hmm.
by chlamydia trachomatis and gonorrhea. These are the most common causes. Okay. So then, what is the most common presentation if your patient has PID? So that is discharge. Pain is second one, like the discharge can be there. As you know, that woman can have like normal physiological discharge, and she
Mm-hmm.
can have the changes with the phase of the menstrual cycle, because in the estrogenic phase, the discharge in the first half of the cycle, the discharge is going to be very thin. Okay, but in the later half of the cycle, it is going to be very thick because of the progesterone. So abnormal discharge, that is characterized by change of color, consistency, volume or odor, and may be associated with symptoms such as itch, soreness, dysuria, pelvic pain, intermenstrual bleeding, or postcoital bleeding. In women of reproductive age complaining of vaginal discharge, the most common cause is physiological, but we need to exclude infective and other causes. So read the question carefully. If they ask you what is the most common type of discharge, your answer is physiological. Okay,
Physiological.
that is the one. Okay, so this is the most common cause, the physiological one. That is how we are going to offer differential diagnosis. We have to see the cyclicity of the discharge, and this is like a diagnosis of exclusion. You have excluded infection, or you have objectively seen it that there is no smell, nothing. So it means that there is a physiological discharge. So prior to estrogen concentration increasing, so it means that the cervical mucus, it can be like a fertile, clearer. It is like more water is there. It is more wetter and then stretchy, like you can spread, and they will spread across the sheet, and then they are slippery also. After ovulation, progesterone concentration increases, so it alters cervical mucus to become thick and sticky. So as we know, vagina is colonized by lactobacilli and other bacteria from the puberty. Lactobacilli, they metabolize glycogen in the vaginal epithelium to produce lactic acid, and thus the vaginal environment is normally acidic, so the pH is less than 4.5. So less than
Mm-hmm.
4.5. So compare it to the rest of the body, where the pH is maintained at between 7.3 to 7.4. So as compared to the rest of the body, this area is very acidic, and it is because of the lactobacilli. Lactic acid is produced, so that's why glycogen is metabolized, so there is going to be lactic acid. That's why the pH is acidic. Some infections, they will occur when the pH is more acidic, like mycosis, fungal infections, candida, and some infections, they will occur when the pH is more than 4.5, like um, vaginal, like this vaginosis, bacterial vaginosis, like other STIs. So then after
Or when
physiology,
it's more than 4.5.
yeah, more than 4.5. Okay. Then don't worry, we are going to read about them as we will go through the lesson. Regarding the first type of discharge, most common, physiological one. Second one, infective. So the infections, this PID is one thing. PID is the ascending infection through the vaginal canal. So the infective causes, they can be many different, numerous. There can be vaginal infections, there can be non-STIs. Non-STIs which are not transmitted sexually. Mostly they are because of the organisms which are normal commensal of the this genital tract, like bacterial vaginosis, vulvovaginal candidiasis, then STIs which are transmitted sexually, like Trichomonas vaginalis or Trichomoniasis. So then endocervical infections which are caused by chlamydia or gonorrhea. Then PID, which is the ascending infection through the to the upper genital tract. Then regarding the non-infective discharges, there can be foreign bodies like tampons, cervical polyp, and ectropion, cervical ectropion, like the patient is using COCPs. So again, there can be copious discharge. Okay. Then even the genital tract malignancy, especially if there is fallopian tube carcinoma, the patient can have profuse watery discharge. That is one thing. Okay. So similarly, if there is endometrial cancer, it can also present like some discharge. But if there is like excessive discharge, it asks you in the abdomen, where is the cancer? They ask you in the exam. Patient has profuse watery discharge. So what is the possible cause? So in the options, if they have given fallopian tube malignancy, that is going to be the correct answer. Then fistulae.
Okay.
Because patient will have
Is it just
continuous
copious
discharge.
discharge, you said? Or?
Yeah, the discharge, like that, non-infective discharge. If
Okay.
there is profuse watery discharge, so that's why I said genital
Okay.
tract malignancy. Then fistulae, like patient, this fistula, it can be like uretrovaginal, or it can be vesico-vaginal, like between the ureter and the vagina, and then between the bladder and vagina. So then there can be allergic reactions. There can be atrophic vaginitis in the postmenopausal women. So patient has come to you. Most important part is to take a good history. You need to tell the patient that whatever you say is totally confidential.
Mm-hmm.
If you will not reassure your patient, she is not going to give you any history. Okay, so you have to reassure her that whatever she says, her confidentiality is highly respected. We will ask her about the characteristics of the discharge, onset, duration, color, order, consistency, cyclicity, exacerbating factors. We will ask about the associated symptoms like itch, superficial dyspareunia, dysuria. We will ask about symptoms indicative of upper reproductive tract infection like abdominal pain, fever, deep dyspareunia, abnormal bleeding. Sexual history, like patient is at high risk of sexually transmitted infections if her age is less than 25, she has a new partner, or she had more than one partner in the last year. Then any previous STI, because if she had STI before, she is likely to have STI this time also. Regarding obstetric history, we need to ask about pregnancy. How was the postpartum period? Did she run any fevers, any discharges, any abdominal pain? Then after miscarriage, how was the period? And then is she using any contraceptives? Because contraceptives, they give you some protection against the ascending infection by thickening the cervical mucus. Then is there any history of uterine instrumentation, like termination of pregnancy was offered? ERPC has been done, like endoscopic removal of the elective removal of the products of conception. Then hysterosalpingography has been done, hysteroscopy has been done. Then concurrent medications. Is she taking antibiotics, corticosteroids? Because they will antibiotics and the corticosteroids, if the patient has been taking, then the chance of opportunistic infections will increase. Then does she have any medical conditions like diabetes, immunocompromised status, all of these things, okay? So
Yeah.
so you have to take a detailed, a beautiful, good history for that, okay? That is one thing. So then what we have to do, like you will ask about her previous treatments, if she has used any, does she have any immunocompromised status, and is there any relevant condition, symptoms suggestive of PID, like dyspareunia, nature, site, and duration of pain, any abnormal menstrual bleeding, then menstrual history. What was the LMP, intermenstrual or the postcoital bleeds, risk of pregnancy, then a detailed sexual history, which would include recent sexual contacts, contraception, barrier or not, and has the partner had any symptoms, that she is the only one with the symptoms or the partner also has the symptoms. Okay. Then past gynecological history like that. So that is one thing. Anything else that comes to your mind?
No, I think that's all the relevant history.
So the point is that you need to take a good history, okay? Just to show them that you know. So then you have taken the history, then you need to see that any past gynecological history, previous pelvic infections or STIs. Check for allergies to antibiotics. Then on examination, these signs would suggest PID. Like pyrexia is more than 38 degrees centigrade, there is tachycardia. Lower abdominal signs of peritonism, like patient can have localized tenderness, guarding, and rebound. Any abnormal vaginal discharge, like this is red inflamed cervix on speculum examination. So the red inflamed cervix, or like if we are having hemorrhagic spots, we call it strawberry cervix.
Strawberry
In which
cervix, yeah.
condition you are going to see the strawberry cervix? Name it for me.
I think it's trachomatis.
Yeah, you should be sure. Okay, that is because of
Yeah.
Trachomatis vaginalis. Okay, I asked you these questions because they are relevant. Okay, then women who are at low risk of STIs, like they will have no symptoms of other conditions causing vaginal discharge, no symptoms suggestive of upper reproductive tract infections, and the moment they can return for follow-up if symptoms they don't resolve. Symptoms have not developed following a gynecological procedure, and so this is low risk. But if we have done some gynae procedure and it is acting after that, then obviously you know that the instruments are usually sterile, but you never know, by chance something went wrong, like that back was broken, was not given full time in the autoclave, so many things could have gone wrong. So then the symptoms, they are suggestive of like vulvovaginal candidiasis, and this is the first episode of a suspected infection, candidiasis, or is it recurrent? Recurrence is infrequent, like it is less than 4 times a year. But if the recurrence is more of this fungal infections or candidiasis is more than 4 times a year, then you will say that this is chronic and this is like significant. Okay, so it will be frequent if she is having like more than 4 times a year. Less than 4 times a year, there's candidiasis, so that is infrequent. So characteristic symptoms of the bacterial vaginosis, and is it the first episode of the suspected BV, or if it is recurrent, then when was the previous episode, and what was the behavior? Was it confirmed and the patient had similar symptoms and she received treatment and she responded to the treatment or not? So previous diagnosis of PV, it can be assumed to be reliable if the patient has signs and symptoms which are specific of the BV. Then symptoms and signs of other conditions causing vaginal discharge, they were absent. Then there was no microbiological evidence of presence of any other infection from the swabs. So you have seen the patient, you have taken a history, you will offer the general physical examination. The patient is going to be like in bad mood because she's suffering. Okay, she may look unhappy, she may look worried. After that, you need to do the abdominal examination. Why the abdominal examination? Like you have to do the to see that is there any mass, so you is there any other problem or not, like that. General physical examination, then the abdominal exams. Why you will do the abdominal exam? You will look for tenderness, right?
Okay.
Tenderness, ascites, any masses, all of these things. Then you will do the local examination inspection. Is there any sign of vulval inflammation? Red, hot, tender, and inflamed. The pain is also there like that. Okay. Then excoriation. Has the patient been itching? Then are there any vulval satellite lesions? And there is erythema. So if you get vulval satellite lesions, always think about candidiasis. So we
Candida.
also, yeah. So this is candida. They will tell you this is the specific description that vulval satellite lesions. So they are on the thigh. So you have to think about candidiasis. After that, with consent of patient and in the presence of a chaperone, you are going to do the speculum examination. So you will look for signs of cervicitis, inflammation of the cervix, infection in the vagina, the amount and the discharge and the color of the vaginal discharge, and there may be a foreign body. Like this is an adult, but still maybe she forgot some small tampon. She didn't remember. She forgot some piece of tissue paper like that. After that, you are going to do the bimanual palpation, like we need to do this cervical motion tenderness, and like we will move the cervix and the patient will feel severe pain in the lower abdomen. Then we will say that this sign is positive. We have to palpate the uterus also for tenderness, adnexia, and the abnormal masses. So pH testing of the vaginal discharge, it can be done on the narrow range pH paper. It can be done into the lab, and you can see, and you must have seen many consultants that they will take the swab, they will make the slide, and they will visualize that under electron microscope on the spot because they have been trained for it. Okay. So in bacterial vaginosis or the like the Trichomonas vaginalis, the pH is going to be more than 4.5, and it cannot distinguish between the bacterial vaginosis and trichomoniasis, or the candida will be suspected if the pH is less than 4.5. So symptoms and signs, they are cleared following the antibiotic treatment. Cervical excitation, tenderness, and the pain, which is elicited on bimanual pelvic examination, and also the adnexia are full or there is any tenderness. So examination can be omitted, like this examination is not convenient for everyone. Okay, so we can omit this examination if the patient has already received empirical treatment like general treatment, umbrella treatment, which is covering all pathogens, all common pathogens like that. Swabs may be omitted with the empirical treatment. Non-offensive wide discharge with itch, then you have to think, then you will treat with antifungals. Offensive discharge without itch, then you have to think about the bacterial vaginosis, so you need to treat it with metronidazole. So if the patient is, if there is recurrence or the failed treatment, then you will leave the, if it is recurrent infection or failed treatment, but the diagnosis is already there, so then you can leave this patient without examination and just change the drug. Okay. Anyone outside except these women, like who didn't receive any empirical treatment, then they don't have like any discharge, but they have pain, or maybe they have discharge, but they don't have these features like that. So, okay, not wide discharge and not offensive wide discharge without itch. So all other infections, all other women, they will need examination with their consent, right? Then you will have to see that this patient is having cervicitis or she is having PID like that. So local investigation is important. So as we know that patient, if she has cervicitis or she has PID, she will have vaginal discharge, which is associated with postcoital bleeds and intermenstrual bleed. She may have lower abdominal pain. She can have, which the pain can be associated with fever or without fever. There can be dysphoria and there can be deep dyspareunia. That is in the PID, the symptoms, okay? And if your patient has like, these are the features of the PID, okay? If your patient
Yeah.
has, if your patient has like, I would say that she has cervicitis, she will have inflamed cervix. And if you are taking a swab and you will just touch the cervix with it with lateral pressure, it will start bleeding, okay? And it is associated with the mucopurulent discharge. Adnexal tenderness and cervical motion excitation on bimanual examination. It can occur in both conditions. Then what investigations should be done? Swabs are recommended. So then clinical features are not clearly suggestive of either bacterial vaginosis or vesicovaginal candidiasis. So you don't suspect bacterial vaginosis because we see that thin grey watery discharge with a fishy odor when we will use amines. If copious greyish thin discharge is not there, or if whitish discharge is not there, these two things have been excluded, then you will just take the swabs. If you see the greyish copious discharge, you will say that this is bacterial vaginosis. If you will see white curdy discharge or the clumps are already there on the vulva in the vagina, then you will say that this is vesicovaginal candidiasis. So the things are clear. So swabs are not indicated. Okay. So this patient, if she has these infections, she is at an increased risk of STI. And just assess that she's in the high risk age group, like less than 25. Her behavior is like this, like she's sexually active with many people. Then if she has like cervicitis on examination, then you should suspect the PID, or she has poor response. So when you will suspect PID, so you should suspect PID if the patient has a poor response to initial treatment, she has recurrent discharge. You treat it and again the patient has discharge. And then discharge of uncertain cause and discharge after gynecological procedure or childbirth within 3 weeks of IUCD insertion. And the women request investigations or the high vaginal swab was taken from the lateral vaginal wall and the posterior fornix, and then microscopy has to be done. Okay, high swab we are taking from there, and now there is a place for the low swab also. That is one thing. Okay, then you have taken the fluid, you are going to do the microscopy, and you can see, and you can do the gram staining. Okay, in bacterial vaginosis we are going to see the clue cells. These clue cells are the epithelial cells which are laden with the dead bacterial cells, so we call them clue cells. Okay, and then we can see like proportions of the lactobacilli and other organisms. In Candida, you are going to see the spores and pseudohyphae. Okay, as we will go to the
So
specific
clue
topics.
cells is
Yeah,
is
the
the
bacterial vaginosis.
physiognomic of bacterial vaginosis.
Bacterial vaginosis. That's correct. So as we will go to the specific topics, I will show you more slides. Don't worry. So we have taken the discharge. We will make the wet mount, and then we will do the microscopy. Okay. So we can see on microscope, we can see flagellate protozoa. Then we will say that this is Trichomonas vaginalis. If there is Candida, then we are going to see the pseudohyphae, like the branching pattern of the cactus, like that. Okay. After that, we can do the culture. For culture, for which organism we can do culture? Candida, bacterial vaginosis, chlamydia, and gonorrhea. Gonorrhea, they are asking in the SPA which special medium is required for growing gonorrhea. That is chocolate agar medium. Then HVS should be taken for suspected Trichomonas vaginalis, and it should be examined in the lab within 6 hours. So it is therefore recommended that these women, they are referred to the gum clinic. Endocervical swabs, they should be taken for chlamydia and gonorrhea, and swabs from other sites, they may be appropriate based on the clinical history, like the urethral, rectal, and the oropharyngeal, depending upon the practices and the habits of the person which we are investigating. So if the patient is there with PID, what immediate investigations should be done? Vaginal or the cervical neck nucleic acid amplification test should be done for chlamydia and gonorrhea, and plus minus culture swab if gonorrhea suspected, and depending upon the local prevalence and local availability of the testing. So then we have to do the urine pregnancy test to exclude pregnancy. This is very important, to exclude the pregnancy. Why it is important? Because it is going to determine that which treatment should be given. Okay. So because in pregnancy you can give certain treatments, and outside pregnancy you can give other treatments. That's why it is important. That is the point. So to exclude pregnancy. Then full blood counts, C-reactive protein, erythrocyte sedimentation rate. These are non-specific, but they are usually done to support the diagnosis. You know, the CRP, C-reactive protein. This is an inflammatory marker. If there is inflammation, then it will be positive. That is the rationale. So investigations may be required if symptoms and signs persist, or in more severe cases where pelvic abscess formation is suspected. What is the difference between the infection and the abscess? Abscess will be walled by the cells, and then the infected material is contained inside the cell. That is what we call abscess, and the treatment of the abscess is drainage. Okay, if it is not responding to therapy because the wall, it is a walled like lesion, so the antibiotic may not enter it like that. So then you have done everything. After that, you should, after taking the swabs and the examination, you should go for transabdominal or the transvaginal ultrasound. That is the point. Okay? And in some cases, we will have to do the diagnostic laparoscopy, but mostly we don't have to do that. But the diagnostic laparoscopy, like I have shown you, that there can be Fish-Hugh-Curtis syndrome if the patient is having recurrent STIs. So don't have to wait for the results, and you can start the treatment. So empirically, you can treat while waiting for the swab results, and where you should start the treatment. Cervicitis is there, then treat for the chlamydia, and then for the suspected PID, then for the bacterial vaginosis and vesicovaginal fistula, you are going to start the treatment without waiting for the results. So if you are suspecting TB, Trichomonas vaginalis, when you will suspect? When there is yellowish green frothy discharge, then you will say that this is Trichomonas vaginalis. Okay, so then we can refer to the if the referral to the gum clinic is not feasible, like it is far or the patient doesn't want to go there, then we are going to start the treatment with flagell. That is the metronidazole. Okay, so then we should know that there are different regimens for treating PID. So like 500 mg ceftriaxone, it should be given intramuscularly single dose, and the doxycycline 100 mg twice daily for 14 days, and then metronidazole 400 mg twice daily for 14 days. This is the most commonly recommended regimen. Okay?
Yeah.
Triple cover like that. Then for more severe disease, IV antibiotic regime as outlined in the guideline. The same things, but you will have to give them IV. In rare cases where like a continuing pregnancy is confirmed, then special care should be taken to avoid possible teratogenicity. That is one thing. Okay. So then, like if you then in pregnancy we cannot give doxycycline, so we should hold doxy, but we can give ceftriaxone and we can also give metronidazole. So if the patient is pregnant, again we cannot give them ofloxacin. Okay. So we will give them just ampicillin and metronidazole. Metronidazole, it can be given in all trimesters of pregnancy like that. And then at the same time, what we have to do, like laparoscopic laparotomy or radiological drainage of the pelvic abscess, it may be needed in severe cases where the tubo-ovarian abscess has formed. Why? Because the patient will have severe pain and he will not be responding to therapy, so we will need to drain the abscess. So then also we need to consult the patient. We need to give information of this STI without mentioning the name. You are familiar with their system, that we need to inform the people at risk. Okay, so
Yeah.
then they will follow up in the gum services, so full STI screen including HIV and the syphilis, contact tracing and the treatment. Follow-up checks to ensure that patient has been effectively trained, effectively treated like that. Their favorite question, what are the long-term sequelae of the PID? Infertility, ectopic pregnancy, pelvic abscess, and chronic pelvic pain. So all of these four are like very serious conditions. Okay, so they will give you a combo that the patient had PID. So what do you expect to see in the long run? So this cord you are going to see. And you know, all of these are important, and you need to tell the patient that as the number of the STIs will episodes will increase, the chance of complications will also increase like that. Okay. So the sexual history taking is very important. What is the aim? You have to show empathy, like you would step into the feet of the patient because they are suffering like that. So how you will feel if you are in their place, okay? You have to actively demonstrate respect and allay anxiety of the patient. You know, these questions are important for the OSCE also. So you should say
Yeah.
one sentence. Take the name of the patient and say that your confidentiality will be maintained at all costs. What you say here stays here. Your confidentiality is protected. So you can say anything that you want to say. So you're going to identify and assess symptoms and the risk of the STI, guide examination and test required, then identify sites needing to be sampled depending upon the sexual practices. Then you need to confirm timing of the sexual exposure to assemble reliability, to assess reliability of a test and possibility of window period. Window period when the infection is there but it has not become evident because the bacteria they are still multiplying into the system of the patient like that. Okay, so that is the window period, the time between appearance of the between the uh, between acquiring the infection and then displaying the signs and symptoms of the infection. That is the window period. Assess the risk of pregnancy or the blood-borne viruses, enable partner notification, identify the need for the health promotion, that what are the lapses, how we can improve the health. Opening sentence, STIs are so common that I would like to ask you some personal questions. So, to assess your possible risk, would that be okay? She will say yes.
Mhm.
Then, what are the presenting complaints? What are the symptoms? What is the history of present illness, last sexual contact, date of the last contact, type of relationship? She is like having a monogamous relationship or she has multiple partners, genders of the partners. Are you sexually active with women, men, or both? Then is it regular contact or casual? For how long she's with the same person? Then is she in touch with these partners or not? So we need to know that we can trace them or we cannot trace them. Then how long have you been having sex? How long have they been having sex for? The type of the sex, vaginal or anal, giving, receiving. Then are they using any condoms? Then any suspected infections, infection risk or the symptoms in their partner, then previous sexual partner details as for last sexual contact. Then if in the last 3 months, then what was the total number of the partners in the last 3 months, and if she has like more than 2 episodes in the last 3 months. 2 episodes and now she has come to you with the third episode and it has all occurred in the last 3 months, so you need to ask her about the number of the partners for the tracing. LMP, menstrual pattern, bleeding pattern has changed. Is it there a possibility that she is pregnant and which could indicate an infection? Then what contraception she is taking, like need for the, does she need emergency contraception? Maybe you are dealing with a victim of sexual assault. Cervical cytology history, then obstetric and the gynecological history, and then blood-borne virus risk assessment and vaccination history like HPV, hepatitis for those at risk. Then past medical and surgical history, medication history including allergies. So additional questions that can be asked, but they are not mandatory. Like we can ask them, what is the are they victim of gender-based violence? Any history of intimate partner violence? You need to ask her that how are things at home? Do you feel safe at home? That is very important, okay? Because in cases of intimate partner violence, we are often ignoring them, and then it can result in death of patient. Then are they taking any alcohol and recreation drugs? What is the history? You should record that. Then how results will be conveyed to the woman. Then you need to establish competency, that is she is going to take the drugs regularly, as you will to check her compliance. Okay, if it is in doubt, then it is an indication to admit them. Assess safeguarding. Are there children at home? Are there any vulnerable adults? So then you should know about the chemsex also. Like it means that that the people who are having these sexual practices, they are using drugs to enhance their sexual experience. Like they will take the drugs and they will party and they will play, like they can be high, and almost exclusively it is used, this camp sex is used when the men are having sex with men, and then they will go to the women and they will spread the infections to them also. Like what drugs they can be using: crystal meth, like it can be smoked, like can be like other smoked and the snorted or the injected forms can be there, like GHB, like it can reduce the inhibitions that things are swallowed, like it is swallowed, and then methadone, like it will cause euphoria and the affection, so it can be snorted or it can be like injected like that. Okay, crystal meth. Only once I remember that they asked this question, that what are these drugs. Okay, because these things are common, like people don't volunteer, or maybe they tell in the term clinics, but these things may occur. Other drugs may
Okay.
include, um, you know, these are just the design.
Do I have to know these drugs or?
Just a couple of them. Like this one, they have asked
Okay.
several times that what is the date rape drug. So this is propinerol. Don't forget this one, because this question,
Okay.
like the candidates are telling us, this question has been asked several times. Propinerol. Okay,
Okay.
and then the screening test is test in the asymptomatic patient. So in the women, we have to see that they can give us self-collected vulvovaginal or the anal swabs. They can do it themselves, okay? Like they can do inside hospital. So the swab is there, so we have to take for the chlamydia and the gonorrhea, and the NAT test is done. And blood tests, they are done for the HIV and also for the syphilis. In both conditions, we are going to do the blood test. In the heterosexual men, because all of this info taken from the BASH guideline. Okay, so we need to take the first gas urine sample, because chlamydia, it can cause infection in the UTI in the men also, in the female also, and then we have taken these tests. We will send them for NAT, and the blood will go for the HIV antibodies and for the syphilis antibodies. In the men, again, the NAT, first gas urine, rectal swab, and the throat swab. Blood for HIV, syphilis, and hepatitis B, C also. So then in the latent phase, the window period, we should know that we need to, like when the patient will give history of exposure. So if there is history of exposure to someone who had chlamydia and gonorrhea, then it will take 2 weeks before this patient will become positive. HIV serology, it will become positive 4 weeks after exposure. And syphilis serology, it can become like positive between 9 to 90 days, like that. Okay. Then hepatitis B serology, it will be positive after 6 months. That is the point.
Do we not? Do we need to remember that?
Just
It's like.
remember, because if they say that patient had exposure to the HIV, but the test is negative at 2 weeks, okay? So then you should know that the test will become positive only after 4 weeks, because before 4 weeks, this is called window period, when the infection is there, but it is not visible in the system, okay? It is not apparent. So that's why, so they will ask you what is the cause.
Okay.
So obviously we have tested the patient too early, that's why we are not finding anything. So that's why the exposure. Just remember, like 2 weeks in gonorrhea and the chlamydia, and 4 weeks in the HIV. So the Hepa B, 6 months, and then syphilis, it can become positive
3 months.
in 9 days to 90 days, 9 to 90. Remember it like that, okay? Then for the specific infections, like now we are going to talk about the specific infections like human papillomavirus. Like this is a large family of the DNA viruses. It is transmitted by skin to skin contact, and there are more than 100 types of the HPV, and 40 they can infect the human genital tract. Then high risk types, they can cause genital tract malignancies like the cervical, vulval, anal, penile, and the cancers in the head and neck. So then the low risk types, they do not cause cancer. So low risk types are the HPV type 6 and 11. So they are going to cause genital warts, and they are positive in more than 75% of the genital warts. So anogenital warts, the patient will be like totally symptom free, but why they will seek treatment? Because of the cosmetic problem, a psychological problem, and psychosexual distress. So around 80% of the people population, they will be infected with one type of HPV in their life, because as you know, HPV is a common commensal, but this is they are of low risk type. Okay. But high risk type, it means that the patient has some exposure or something and they are cancerous. So the warts are more common in the people who are younger than 30, and mostly these warts are benign and asymptomatic. And 90% of the human papillomaviral infections, they will clear without any treatment, without any investigation. They will clear within 2 years. So if the patient has like, how do we investigate the epidemiology and pathology of the HPV related disease? Screening is essential. So regular cervical screening can prevent about 75% of the cervical cancer in the woman. And we have to give the message to the patients, the masses, that they can be protected from a deadly disease only if they will take a simple vaccination. So the genital warts, they can be identified on the simple examination. And like if you cannot see anything, then we can use the magnifying glass. If there is suspicion of dysplasia, then a colposcopic assessment it can be done with a biopsy. For women where the speculum examination is recommended at the first presentation, and proctoscopy is advisable if the patient has anal warts. Okay. So first of all, like simple examination, and then we have to do the proctoscopy like that, depending upon the practices of the patient. If they have symptoms like they have rectal discharge, bleeding, or there is irritation. Irritation, the human papillomavirus, it can cause itching, persistent itching, which will not respond to anything. So the anogenital warts or the condyloma acuminata, this is how they look. Like this is, if you will see, they can have like variable presentation, but here you can see that these are the warts like that. Okay. Simple lesions are there. They look like transparent lesions, but they can be present in the genital area like that. Okay. So they are transparent human papillomavirus type 6 and 11. So these are benign, but they look bad, uncomfortable. They cause stress to the patient. The incidence is likely to decrease significantly in the vaccinated people with quadrivalent HPV vaccine, which is Gardasil. Okay. And Gardasil will have the antibodies against. They have actually virus, peptone-like virus particles. Okay. So in these
Sorry, say this
Gardasil,
again. Sorry, yeah.
virus-like,
Sorry, say this.
yeah, virus-like peptone particles. Okay, virus-like particles, peptones. They are present in the
Okay.
vaccination. So this vaccination is against HPV type 6, 11, 16, and 18. Okay, that is the point. So genital warts, they are common and they are benign, and we need treatment only for cosmesis, or patient may not like to have any treatment. And like if they will use like barrier methods like condoms, then it may reduce the risk by 30% because the virus can pass through the plastic sheets. That is the problem. Okay. There can be recurrence is common. There can be trauma to the skin, for example, from shaving, and they can cause the warts to spread or reoccur. Smoking cessation is important. Smokers, they are more likely to have recurrence, poorer response to the treatment, and limited evidence on best treatment for the genital warts. So these patients, they may require multiple treatments, and multiple modalities are available, and the therapy can be given for weeks to be effective. It will take long time, okay? And all treatments are associated with possible failure and or recurrence. Like one drug that can be used, it is podophyllatoxin. Podophyllatoxin, so this is home-based treatment. Patient will apply the solution or cream to the warts twice daily for 3 days, and then they will have a 4-day period of no treatment, and this is repeated for 4 to 5 cycles or less if the warts they clear before then. So they can cause irritation to the surrounding skin, and they are licensed for use on the external genitalia only. Then intercourse, it should be avoided following application of the podophyllene because it may cause severe irritation to the partner also. Second treatment is Micomode. Micomode, this is immunomodulator. This is also like home-based therapy, and the patient applies cream before bed 3 times per day and washes off 6 to 10 hours after the application. So it can be used for up to 16 weeks and then it can cause skin irritation. It is known to weaken the latex condom, so patients should be concerned about using the alternative type of contraception. Then it should not be applied prior to the intercourse as it can cause irritation to the partner. Third treatment that we had for the treatment of benign warts, it is called Tritone acetic acid or common household vinegar. So it may be applied by a clinician in a specialist clinic because it is applied weekly and there is application of 80 to 90% solution. So it is a caustic agent that causes cellular necrosis which is associated with intense burning and irritation for up to 10 minutes post application. That's why it is given into the wall. Then it is not recommended for large volume warts. It can be used at most anatomical sites. Like here it has been applied, so maybe it will result in the local burning like that, but the number of warts it will decrease. So then after that, like after these treatments, there is another treatment which is called the cryotherapy. This cryotherapy, like cold therapy, it is offered with liquid nitrogen, commonly used or ablative method. It needs to be carried out in a clinical setting and with access to the liquid nitrogen and relevant safety equipment. Each lesion is frozen with spray until a white halo forms, and treatment is repeated every 7 to 14 days. So after this cryotherapy, we can also offer surgery or electrocautery. So here we are applying heat, and when we do it, it depends that how many lesions are present and what are the positions and what is the size of these lesions. So not treating the warts is also an option in approximate 30% of the patients, and the warts they will resolve spontaneously. From the exam viewpoint, there can be a specific condition like the patient has come to you and has come in pregnancy. So what problems can occur? So porphyrin we don't like to give because it can go into the genetic material and it can be teratogenic. So treatment of the genital wart in pregnancy is difficult
Cryotherapy.
as the altered immune response reduces efficacy of the treatment. So they are also limited by potential toxicity and teratogenicity of some treatment. Cryo and the excisions, they are the only treatments recommended in pregnancy, and the tricyclic acid cycle, which is the vinegar, this can also be used. So these patients, the genital warts are very large and they are obstructing the birth canal. Only then operative birth is indicated. Then fetal or the fetus is at risk of recurrent respiratory papillomatosis. It is very rare, but still it is a possibility. So the baby should be seen by the pediatrician. The chance is very low.
So section is only,
Yeah, if there is
sorry,
a large
section is only for,
growth
okay.
which is obstructing the birth canal. Otherwise, you will go for cesarean section. You will go for
So there is no risk of
yeah,
transmission to the baby.
yeah.
Okay.
The risk of transmission, 4 per 100,000. They can have respiratory papillomatosis. That is the point. Okay. So then the question is, can we prevent HPV related disease? So no specific treatment available for eradication of the HPV because if a normal person has a normal immunity, then it is cleared of the system in within 2 years like that. Okay. So we can give the vaccines. So different types of vaccines are available, like bivalent vaccine, which is Cerevarix, and it is actively provides immunity against HPV type 16 and 18. Okay, so two types. These two types are strongly linked to the development of the cervical cancer. So in 2012, other vaccine was developed, that is Gardasil. It provides protection against HPV type 6, 11, 16, 18. And now the recommended one is Nonavailant. So for genital warts, the visual inspection examination, which is aided by magnifying glass, so and that is recommended. That is the recommended test for routine diagnosis. This now we are using this nonavalent vaccination, okay, which contains which is active against all these four types plus other types like HPV 31, 33, 35, 40, 41 and 45, all of these types, but you don't have to remember, just remember nonavalent is recommended now. So but it is not
So this is the recommended
the
one,
recommended
number
one.
3.
Yeah, so either you should give
No.
Gardasil, because previously we have been using Gardasil, and by now the everyone, the ACOG, the Saudi, the Canadian Society, the RCOG, everyone is suggesting that we should give that nonavalent, okay, but the world is gradually
Okay.
shifting to that one, okay. Then proctoscopy, if the patient was having like this inner warts, then if the base cannot be identified, then we will have to see that the symptoms are there, and like we cannot see, so we will have to do the proctoscopy like that. So then we know that about 15 different types are associated with the cancer, but we are concerned mostly with the type 16 and
16 and
18. Yeah, because they are going to cause the cancer, and the type 6 and 11 because they are going to cause the warts.
warts.
So the treatment of the warts is difficult in the pregnancy, so that is one concern. Otherwise, rest of the things are fine like that. So that's all you need to know about the human papillomavirus. So the vaccinations. So if they ask you that vaccinations are like primary protection, primary type, or primary prevention, because we are trying to control the risk factors like that. Okay. So how effective is the vaccination? 97%. That is the point. Okay.
97. Okay.
Yeah, 97. Now the sexually transmitted infection. So we said the bacterial infections. Bacterial we already said gonorrhea, which is caused by Neisseria gonorrhea, chlamydia, which is the Chlamydia trachomatis, doesn't have a cell wall, very thin cell membrane. Whereas then the gonorrhea, they will tell you that gram-negative diplococci. So you have to think about gonorrhea.
Gonorrhea.
Then there can be non-gonococcus urethritis. So it means that patient has developed Chlamydia trachomatis or Mycoplasma genitalium. Then chancroid, it is caused by Haemophilus ducrei. Then granuloma in Gynae. So granuloma in Gynae, that is caused by the Clamatobacterium granulomatis. Which one?
I
Granuloma in Gynae. Then
hate
lymphogranuloma.
this.
Yeah, this is, but you know they will tell you that rapidly the ulcer has developed and you applied the steroids and rapidly disappeared. So that is granuloma in Gynae. Then there can be lymphogranuloma venereum caused by Chlamydia trachomatis. Then syphilis. Syphilis caused by Treponema pallidum.
Pallidum.
Caused by Mycoplasma hominis. The virals, we said that the genital herpes, like the type 1, type 2, type 1 you will cause the labial, and the type 2 will cause the genital ulcers. But now the incidence of the type 1 herpes is also increasing. Then the genital warts, like we said, HPV, hepatitis infection, all A, B, C, D, and E, and virus type like from A to E. Then
Mhm.
HIV, and when it will develop into full-blown symptom, then we call it AIDS. Then molluscum contagiosum caused by the pox virus. Protozoal infections like trichomoniasis, this is called by the Trichomonas vaginalis. Fungal infections, they can be yeast in the form of Candida albicans. Then parasites can also cause infection. Which parasites? Like there can be pubic lice or there can be cramps. These are caused by pediculosis pubis. Then patient can have scabies, and scabies is caused by Sarcoptes scabiei. That is the point. So genital ulcers, another favorite area. So you can
Yeah.
classify them in different ways. Like the easiest one will be that is the ulcer painful or painless? If the ulcer is painful, then you have to think about the herpes, which can be due to type 1, type 2, and what type of pain will be there. Burning pain will be
But
there, okay?
pen,
In
yeah.
then cancroids, like that, which is caused by the Haemophilus ducrei, and then the systemic conditions like Behçet syndrome. So patient will have like weeping ulcers, like eczematous radish ulcers. So these are because of these three conditions if they are painful. If it is painless ulcers in the primary, it can be like primary, which is canker, or in the condylomata later. Then condylomata accumulata, they are also painless. Granuloma in Gynae, also painless. And the ducrei is going to be like cancroid is going to be painful. Herpes cancroid unit. Okay, then remember that cancroid is caused by Haemophilus ducrei, and this one is caused granuloma in Gynae caused by a variety of uh, Calimamato bacterium granulomatis. In the SBA, your top
So,
will be
yeah.
yeah.
Syphilis, I'm always confused that syphilis causes chancroid as well. No,
Yeah,
chancre, yeah.
yeah,
Different
canker
from the
will
chancre.
cause, yeah. Syphilis will cause, the different lesions. Primary one is canker, and then there will be condylomata later, like that, okay? So then in the last stage, it will cause gumbatous ulcer. And the cancroid, that is called by Haemophilus ducrei, and that is painful, okay? And syphilitic ulcers, they are painless. Is it clear?
Yes, yeah,
Yeah, so
clear.
you need to remember this definitely, this info, because important, okay? So lymphogranuloma malarium, this is also called by Chlamydia trachomatis. Which type? 2, 3, 4. LGV Chlamydia trachomatis types 2, 3, and 4. That is the. So in the TB, the patient will have serpiginous ulcers. Serpiginous means that they are like the serpents, like the snake, irregular edges. Running ulcers and irregular. Okay. Then the rolled out
Okay.
margins. The rolled out margins, like they have a border which is rolled outwards, so you have to think about the VIN. So in case of the syphilis, you will have, they will tell you punched out lesions like that. Okay, so all of these conditions are going to be painless. Now the most common infection, chlamydia. Okay, the most common bacterial infection. Otherwise, the most common
Yeah.
discharge, physiological, and the most common one will
Physiology.
be bacterial vaginosis. So, chlamydia is the most common treatable sexually transmitted infection. So, the most common preventable cause of infertility worldwide, caused by intracellular gram-negative bacteria that infects the columnar epithelium and the transitional epithelium. So, columnar epithelium we have on the outer surface of the cervix. Inner surface of the cervix, that is going to be the columnar epithelium. And the prevalence of the chlamydia infection, that is between like 1.5 to 10% in 15 to 25-year-old people, like that. This is how the chlamydia looks, like the greenish bluish like that under electron microscope. What are the risk factors for the chlamydial infection? These are young age, less than 25, new sexual partner within the past year, then poor socio-economic status, use of non-barrier contraception, infection with other STIs. So the rule is, if the patient has one STI, you have to check for the other STIs, because it is very rare that the patient will have just one type of um, like
Yes.
what is the time uh, for this one, okay? So for the chlamydia, then the symptoms and signs of the chlamydial infection. So you should know that, so if patient has one STI, you have to test them for the other forms of STI also, like that. So the majority of the infected individuals, they will be asymptomatic. But those who have symptoms, what are the common symptoms? There can be vaginal discharge, dysuria, intermenstrual bleeding can be there, postcoital bleeds can be there, so the cervix will be friable. So those women who progress to develop PID, then what will happen? They can have the pelvic pain. If they have progressed to PID, they will have pelvic pain, dyspareunia, general malaise and malaria and pyrexia. And sequelae that we have discussed before, but we will mention here also: PID, infertility, chronic pelvic pain, increased risk of ectopic pregnancy. So men with a chlamydial infection, they are more likely to be symptomatic than the women. But men will have dysuria and they can have like urethral discharge, which is being the most common presenting symptom. And they may also develop epididymoorchitis with testicular or the epididymal pain and the swelling. A small number of the adults, they may present with arthritic symptoms, like they will say that they can't pee and they can't climb a tree, like that. Okay. So then another syndrome is called Retter's syndrome. This syndrome includes urethritis, arthritis, and conjunctivitis, because we said that it can infect a specific type of epithelial lining, so it can infect the eyes, the bladder, and the joints, like that. So rarely there will be development of the right upper quadrant pain due to the perihepatitis occurring in the women with the Fizz-Hugh-Curtis syndrome. Like we started our class with these
Yeah.
adhesions, okay? Fizz-Hugh-Curtis, and
Yeah.
this is the mucopurulent discharge from the cervix, like that is.
Yeah.
Then what are the clinical signs? Non-specific, other than urethral discharge in the men, and in the woman, the cervix may appear reddened and friable with contact. There will be bleeding, and there may be discomfort on the bimanual examination. Mostly these are diagnosed during investigations for other suspected STIs or during specific clinical episodes, such as routine testing prior to the induced miscarriage or insertion of an IUD. So if the patient is young, her lifestyle is like very high risk, then even before inserting the IUCD, we need to exclude the infection, otherwise we can cause PID. So you have done certain testing, and how you will patient has some discharge, how you will diagnose that she is having some problem, like that. Okay. So
Yeah.
we will go and
Do
we
the
will
nut
see.
test.
Yeah, we will need to see that. So how do we do that? Like we will come here. There are a number of different techniques for detecting chlamydial infection, including cell culture and enzyme immunoassay. Nucleic acid amplification tests are preferred because of their high sensitivity, like 90 to 95, and specificity, that is 97 to 99%. Nucleic acid amplification tests have the advantage of the chlamydial detection from first void urine samples, like both in the men and the women. And self-administered low swabs can be taken, and in the men, first catch urine can be taken. Rectal samples in the men or the woman, they can be taken blind or they can be done under a proctoscopy. So window period of detecting the chlamydial infection is 2 weeks. So 2 weeks between exposure, 2 weeks should be there, should be given between the time of exposure and taking the sample. Before that, it is unlikely to find anything. So in a symptomatic patient where the STI is suspected, full STI screen is mandatory, since chlamydia and other STIs such as gonorrhea, they can often coexist. So how do we manage chlamydial infections? So the natural history of the chlamydial infection is unclear. Okay? Some asymptomatic individuals infections, they can resolve spontaneously, and treatment of the infected individual is always recommended to avoid possible progression to the more serious problems like PID in the women. Then PID is one of the things. Other serious problems can be perihepatitis, Reiter syndrome, pregnancy-related complications, fertility in women with and possibly in the men, and they can develop urethral stricture and the chronic pelvic pain. So what general advice you should be giving to the patient? A biopsy, including the oral sex, and with patients and their partners, and complete the treatment, like wait for 7 days if they have been treated with azithromycin. Explain long-term implications. Screen for other STIs if the patient is within the window period of the HIV and the syphilis. Then if the patient is still in the window period, like within 3 months of the exposure, within 1 month for the 3 months for syphilis, and within 4 weeks for HIV infection. Then uncomplicated infection is not an indication for removal of an intrauterine system or intrauterine device. Regarding the counseling, what is important? Contact tracing. Like 2/3 of the sexual partners, they are likely to become infected following sexual intercourse with an asymptomatic chlamydia positive partner. A full STI screen, hepatitis B, syphilis, and HIV, it should be carried out. So the treatment and the contact tracing for the sexual partners within the previous 6 months, it should be done like that. So it can be like performed like the treatment and the contact tracing for the sexual partners within the previous 6 months or 4 weeks if a man with urethral symptoms. And they should receive advice on the safe sex, like they should use the barrier method and they should avoid it unless they have treated the treatment. And they should also see that the partner has also completed the treatment, or they should use the barrier method of contraception. Then refer to the gum clinic and for the STI provision and STI provision, like further testing and assessment. And it will be considered in some instances if the full STI screening and the appropriate counseling and the contact tracing is not available in the level 1 or level 2. And then which antibiotic treatment should be given. So this is when your patient is having chlamydia. Okay, so we will recommend single dose like 1 gram of azithromycin. It will improve patient compliance. We can give doxycycline 100 mg twice daily for 7 days, but it is contraindicated in pregnancy. Why? Because it will cause demyelination of the teeth of the baby like that. Okay, so the alternative regimen include ofloxacin 200 milligram twice daily or 500 mg once daily for 7 days. So this is contraindicated in pregnancy. Erythromycin can be given like 500 milligrams twice daily for 10 to 14 days. So the chlamydial infection, if it occurs in the pregnant woman or the woman who is breastfeeding, so the incidence of such pregnant women, it is like 6%. The PID in the chlamydial infection in the pregnancy, that is 6%. So chlamydia can affect women during pregnancy also. Untreated chlamydial infection in pregnancy is associated with increased risk of miscarriage, premature preterm delivery, fetal growth restrictions, low birth weight, and stillbirth. Then there are certain risks to the neonate of the transmission during delivery, like there can be ophthalmia neonatorum, like it can occur within 5 to 23 days after birth, lower respiratory tract infection, and pneumonia, and all being well recognized in up to 25% of the neonates. NICE recommends that at booking appointment, we should pay attention to the people. We should assess that what is their risk of having these infections, and if they're younger than 25, screening should be done, and the details of the program should be given. Treatment options for the pregnant and the breastfeeding women with the chlamydial infections, these are limited because of the potential teratogenicity of some of the antibiotics, and these, so how we should treat them. These drugs are considered or deemed safe during pregnancy. Like azithromycin 1 gram, it can be given instead. Or what else we can give? We can give azithromycin 1 gram, erythromycin 500 mg 4 times daily for 7 days or twice daily for 14 days. Or we can give amoxicillin 500 mg 3 times daily for 7 days. So remember, azithro and amox and erythromycin, they all can be given to treat chlamydia during pregnancy. So in pregnant women, post-treatment test of cure is recommended due to the risk of serious sequelae for the mother and the neonate if the infection is not treated. So how we should manage the sexual partners? Partner notification, we are going to offer all sexual partners a full STI screen. We will offer epidemiological treatment. If this treatment is declined, we advise patients to abstain from sex unless they have received a negative result. If found to be positive, screen and offer epidemiological treatment to any other potentially exposed partners. A cutoff of 4 weeks is used to identify the sexual partners and who can be potentially at risk of the index patient is. If the patient is symptomatic, that is the point. Okay, so that is one thing. Then we should know that this testing is important, because the problem is that if the patient is not diagnosed or patient is not treated optimally, then what will happen? They will keep developing the infections, and the chance of complications, it will keep increasing like that. So when you are counseling the patient, it means that you have to give them full information on STI screen, contact tracing, treatment, and advice for safe practice. And most importantly, you need to ensure that patient knows that her privacy will be, confidentiality will be maintained, both in cases of men and women. So test of cure is not recommended unless the patient is pregnant and has been non-compliant to the treatment or has been exposed like that.
In case of HIV and the patient declines to tell her partner,
Yeah,
what should be the...
we will encourage her that she should tell. Okay, and we will encourage her to tell the patient. But if she is like uh, hesitant, she doesn't want to share, say something, she doesn't want to share, in that case what she will do, she will ensure her that she is fine, and her confidentiality will be maintained so she can trust us. That is the point. Okay, that is
So
the
we
point.
can't tell her partner
Yeah,
against her
yeah.
wish,
If she will,
even if
we have to.
he's...
No, we have to break the. I was going to that point. We have to break the confidentiality. Why? Because HIV is a serious infection, and it can hook the patient forever, like. So that's why we need to tell them that we will encourage them and they should tell. And if they will not tell, then we will tell. We will, we will keep the name of the patient like what. Um, we will tell the patient that we will tell the person at risk that one of your partners has been diagnosed with this problem, so you are at a greater risk, so it would be better if you can care for yourself, better to get tested for it. Okay, so usually the name, that you have practiced this before, that in the gum, when you are sending to gums, you are not exposing the identity of the patient, right? That is the point, unless it is like very clear like that. So encourage her. If she doesn't tell, then you can tell her, because this patient is living with her, and this other person has been having sex with her, and he is also at risk of developing this HIV. So this is something very serious.
There was a question whether to take an order court to
Yeah.
tell the partner or what to do
No,
exactly. So I
you
was
don't need
confused.
judicial order. Just you can tell her. You can break the confidentiality. In this case, GMC gives you full protection. Okay, because another individual is at risk, and this condition can be quite serious. Okay, so we can't take it lightly. So we need to tell the patient that we are going to break her confidentiality. So that's why we encourage, otherwise we just tell them. That is the point. Okay, and sometimes they can ask you, like, the husband is a physician, and he has the wife is having some affair or something, and she has got an infection, so what you will do? So you need to break the confidentiality. AIDS is HIV is very serious. Even if this other person had syphilis, you are going to tell the other person. Why? Because all infections, they can cause serious problems.
Yeah,
That is the
yeah.
reason. Okay. So
Actually, we had a similar case like that last year, and I
okay.
was so surprised that the hospital...
So it should not
Yeah,
be an
yeah.
issue. Okay. So once the patient has received the treatment, then we will have to wait for 5 weeks. This is also SPA. Your patient has been treated for chlamydia, so when are you going to do the test of cure? Test of cure, we have to do the NAT again. Okay. So if the patient has taken any other treatment, then we will use for 5 weeks. If she has taken, like, say, azithromycin, then we will wait for 6 weeks. As nucleic acid amplification test, it can give false positive results up to 5 weeks following successful treatment, but the antigenic material, it can still be detected even if the bacteria are dead. So it will be false positive. Test will be positive and the disease will be absent. So that's why better to do it after 6 weeks if the patient has taken azithromycin. If she has taken amoxil or the erythromycin, then it can be done at 5 weeks. So all patients treated should be followed up to check that they have completed their course of treatment, and their partners they have been notified and treated, and to reinforce health education messages and to repeat treatment if necessary. Partner notification, testing and treatment that is required. That's all you need to know about chlamydia.
Chlamydia.
Now the second infection, which is most common cause of the STI after
And
chlamydia.
the color of the discharge of chlamydia, is it just
Watery. Watery can be
transparent or
transparent, can be milky white.
transparent?
Okay.
Mm-hmm.
Variable
Okay.
presentation, that is the point. So in cases of gonorrhea, Neisseria gonorrhea is the second most common bacterial STI. Highest incidence is in the males aged 20 to 24 and the females which are 16 to 19 years. So you can see that when they're starting their sexual activity, at that time they have the highest risk. So this is
Mm-hmm.
how the gonorrhea it exists. Like you are going to see two two organisms are here.
Yeah.
They are
Mm-hmm.
gram-negative diplococci, which can exist in pairs. So two, two, and two. That's what you're going to see. Okay, and they can infect the mucous membrane of the urethra, endocervix, rectum, pharynx, and conjunctiva by direct inoculation of infected secretions from one mucous membrane to another. Unlike chlamydial infection, most men they are asymptomatic with dysuria in more than 50% and urethral discharge in more than 80%, and both of which usually they will start within 2 to 5 days of exposure. Patient had oopsie unprotected sexual intercourse 5 days ago. Within 2 to 5 days they can become positive. They can develop symptoms. On the other hand, less than 50% women are symptomatic. So men are symptomatic. More than
Symptomatic.
50 men are symptomatic, and more females, less than 50% are symptomatic. More than 50% will be asymptomatic. Usually with non-specific vaginal discharge, lower abdominal discomfort, and or dysuria. When an STI is suspected, a full STI screen is recommended as gonorrhea may coexist with other sexually transmitted pathogens such as Trichomonas vaginalis and Chlamydia trachomatis. And gonorrhea, it may spread directly to the adjacent organs, like it can involve the epididymis and the prostate also in the men. So how do we diagnose it? The diagnosis can be confirmed by direct culture from swab taken from the infected site and which is plated directly onto the selective culture medium. So, and the culturing the gonorrhea, it has the advantage that antibiotic sensitivities they can be determined. They can also be determined. So, the more sensitive nucleic acid amplification test, it can detect up to 90% of the infected individuals as compared to the only 75% with the culture. So NAT is going to be a better test because we can detect up to 90% of the samples infected people. So what is the treatment of gonorrhea? You should know that right now the people are suffering because there is too much resistance to this ceftriaxone. So first line antibiotics of the choice for uncomplicated anogenital infections in men and women, these are ceftriaxone 250 milligram 8 times plus. This dose is important, okay? 250 milligram
Okay.
as a
Mm-hmm.
single dose with azithromycin. So whenever you are treating gonorrhea, you are treating chlamydia also. So 1 gram can be given orally as a single dose. So taking 1 gram means patient will take 4 tabs. No, this ceftriaxone, it means like we are giving injection, okay? But azithromycin, it is given orally. 1 tab is like 200, so maybe your patient will take 4 or 5 tabs depending upon that this is 250 or 200. If an alternative regimen is required, like patient has allergy, contraindicated to intramuscular injection, or sensitivity results available, then this should be discussed with the local gum clinic and the microbiology to assess local trends and resistance patterns. In addition to the antibiotic treatments, management also includes counseling, screening for other STIs, contact tracing, treatment, and advice on the safe practice, safe sex. Test of cure, it should be done here also, and it should be done, it is recommended in all cases. Like it is recommended by BASH for patients with persistent symptoms or signs after treatment. Culture should be performed at least 72 hours after the treatment, and for the symptomatic patient, a NAT test it should be performed at least 2 weeks post treatment. Regarding follow-up of the patients, like for the test of cure, assessment after treatment to confirm compliance with the treatment, ensure resolution of the symptoms, and inquire about the adverse reactions.
Mhm.
Take a sexual history to explore the possibility of reinfection, pursue partner notification, and health promotion behavior. Test of cure is recommended to identify the emerging resistance. If test of cure needs to be selective, then prioritize the following patients, like the patients
So,
who have.
so sorry.
You're
In the
welcome.
previous,
Yeah,
sorry, in the previous slide, test of cure should be done after 72 hours
after the treatment.
from
We will
the
talk about.
treatment.
Yeah, we are
Yeah,
going
but
to.
then why the NATS is different?
Yeah,
Is
the
it the
net is
same or
different.
not different?
No, the net is different. Like we here we are just going to see with persistent symptoms. The culture should be performed at least 72 hours after treatment.
Uh-huh, okay.
Okay, because their symptoms are not going away. So we need to treat them for 72 hours, and then we can say that this patient is safe and that now we should do, then the result will be like helpful, like the diagnosis can be made. We were not talking about the test of cure. Test of cure we are going to talk about. So test of cure needs to be selective. You are going to prioritize these patients like who have persistent symptoms or signs, they have pharyngeal infection, and all treatments are less effective at eradicating pharyngeal infections. And treatment should be with anything other than the first line recommendations. So what is the method and timing of test of cure? Patient has persistent signs and symptoms. So culture should be done at least 72 hours after completion of therapy. If patient is asymptomatic, then we will do NAT followed by the culture if positive. Then test of cure is done 2 weeks after completion of the antibiotic therapy. Infection should be identified after treatment may well be due to the reinfection. If infection is identified after treatment, then you have to think that this patient has been reinfected. Partner notification is important. Male patients with symptomatic urethral infections, they should notify all partners with whom they have sexual contact within the preceding 2 weeks, or their last partner if long ago, if more than 2 weeks ago. Patients with infection at other sites or asymptomatic infections, they should notify all partners within the preceding 3 months. Offer sexual partners testing and treat epidemiologically for the gonorrhea. To confirm or exclude the infection in patients who attend within 3 days of the sexual contact, consider a second test of cure of test if the effective antimicrobial therapy is not given. Conventionally, this would be like 14 days after contact. Those with positive test of cure, they may have been inadequately treated or may have been reinfected. Culture results, they will guide appropriate treatment. So that's all you need to remember about chlamydia and gonorrhea.